Welcome back, students, to part 120 of our masterclass. Can you believe it? We are officially celebrating the completion of our 12th decade of episodes together. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in part 119, we tackled the advanced medical side of MDC23, really looking at those factors influencing health status. Today, we're taking that foundational knowledge and marching it straight into the operating room. We are embarking on an advanced surgical DRG deep dive into major diagnostic category 23, and we're going to laser focus on living donors and prophylactic surgeries.
Here is our roadmap for today. We'll start with an overview of the MDC23 surgical hierarchy, look at some high-volume surgical families, dive into prophylactic surgeries and donor billing, break down the crucial difference between excision and resection route operations, talk about CC/MCC capture and audit defense, and then wrap it all up.
Let's jump into Section 1, an overview of the MDC23's surgical hierarchy and partitioning.
Now, MDC23 is highly unique. Unlike most major diagnostic categories that group patients based on a specific diseased organ system, MDC23 is all about encounters for factors influencing health status. The surgical partitioning logic here actually relies entirely on precise ICD-10 PCS operating room procedures. When an OR procedure is performed for a living organ donation, or maybe for prophylactic disease risk reduction, the grouper literally bypasses the usual disease hierarchies. It directly triggers a specific MDC23 surgical DRG assignment, which perfectly reflects the specialized resources required to treat inherently healthy, non-diseased tissue for preventative or donor purposes. The clinical spectrum of MDC23 surgery basically spans three distinct buckets. First, we've got living donor organ procurement surgeries. Think donor nephrectomies or partial hepatectomies. Second, we see risk-reducing or prophylactic organ resections, which are usually driven by high-risk genetic mutations like BRCA1 or BRCA2. And finally, there are elective surgical aftercare encounters. But here's the absolutely crucial hierarchy rule you need to remember. If a patient undergoes procedures that cross into multiple categories, living donor procedures will always supersede and take grouping priority over those other OR procedures.
Moving on to Section 2, let's explore those high-volume surgical families, starting with living donor procedures.
When we drill down into IPDRG 952, which covers living donor procedures, the absolute highest volume cases you'll see are renal and liver donations. For renal transplantation, you must meticulously document the surgical approach. Was it an open, laparoscopic, or robotic living donor nephrectomy? Even though they currently group to the same MSDRG, each approach maps differently in ICD-10 PCS. And for liver transplantations, distinguishing between a right versus left lobe partial hepatectomy harvest is critical clinical data that dictates the structural complexity of your procedure code.
Next up, Section 3, prophylactic surgeries and donor billing.
Caring for a living donor isn't just about the surgery. It involves an extensive physiological and psychological workup beforehand. And this is where the billing gets super interesting, and frankly, a bit tricky. There are complex special billing rules that link the donor's medical encounter directly to the organ recipient's insurance coverage. Your revenue integrity teams have to make sure the coding perfectly reflects the donor status. If it doesn't, the transplant facility might not get reimbursed, or you could trigger a massive wave of administrative denials simply because the patient profiles were misaligned.
Now let's shift over to MSDRGs 953 and 954, which capture other OR procedures for factors influencing health status. This is the home base for prophylactic and risk-reducing surgeries. We're talking about life-altering, preventative procedures like a bilateral prophylactic total mastectomy or a bilateral prophylactic salpingo-oophorectomy, often just called a BSO. These are typically indicated by the presence of high-risk genetic mutations, BRCA1, BRCA2, Lynch syndrome, or PALB2. Your documentation here must crystal clearly state the prophylactic intent to medically justify removing non-diseased organs. All right, Section 4. Let's talk root operations, specifically excision versus resection. Selecting the exact ICD-10 PCS root operation is arguably the most important step in MDC23, and the fundamental battle is between excision and resection. Excision is strictly defined as cutting out a portion of a body part, so a partial liver harvest for a donor or a partial prophylactic breast tissue excision, that's an excision. Resection, on the other hand, means cutting out all of a body part. Complete removal of a donor kidney or a complete bilateral total mastectomy is a resection. Mixing these two up will instantly invalidate the clinical truth of your surgical encounter.
Beyond the procedure codes, ICD-10-CM diagnosis sequencing is heavily regulated here. You are dealing with mandatory sequencing guidelines for Z codes, a code from category Z40 for prophylactic organ removal, or category Z52 for living donor status, absolutely must be sequenced as the principal diagnosis. Then, to paint the full clinical picture and back up your medical necessity, that principal code needs to be immediately followed by secondary codes defining the exact risk, like category Z15 for genetic susceptibility or category Z80 for a strong family history of malignancy.
Let's move into Section 5, CC/MCC Capture and Audit Defense.
Now, even though we're talking about populations of healthy donors or folks undergoing elective preventative surgery, complications definitely still happen. Capturing those high-yield secondary CCs and MCCs is vital for accurate severity profiling. Clinical documentation integrity specialists need to be on high alert for things like acute post-hemorrhagic anemia that requires a packed red blood cell transfusion, postoperative atelectasis, pneumonia, or surgical site infections. And don't forget procedure-specific complications, like bile leakage in partial hepatectomy donors, or acute kidney injury following a living donor nephrectomy.
Prophylactic surgeries are basically giant targets for compliance audits and commercial payer denials. Payers will frequently try to deny these claims by labeling them as investigational or non-covered elective procedures. To defend the medical necessity of these prophylactic organ resections, your documentation has to be airtight. The clinical indicators, specifically detailed genetic testing results and a comprehensive family history of malignancy, must be explicitly documented by the attending surgeon. You have to prove this surgery was medically necessary to prevent an imminent, high-probability disease.
To really build an ironclad audit defense, you must continually verify your root operation assignment. If the operative report describes an excision, but decoder bills a resection, that mismatch triggers an automatic audit. Plus, you've got to ensure strict adherence to CMS rules for linking donor and recipient profiles. Ultimately, a strong partnership between the CDI team and the surgeons is the only way to perfectly align the prophylactic intent of the procedure, ensuring nobody accidentally codes it as a therapeutic treatment for an active disease that doesn't even exist yet.
Finally, Section 6. Let's do a quick summary and talk next steps. To summarize the core mechanics we've covered today, MDC23 grouping logic is incredibly unique because it deliberately bypasses standard disease hierarchies. It successfully triggers surgical DRG assignments for essentially non-diseased states, relying entirely on the specific operating room procedures performed. And please always remember the hierarchy. Living donor procedures in MSDRG 952 will always group first, completely superseding the prophylactic surgeries found in MSDRGs 953 and 954. The backbone of all compliant coding in this category is precision. Your ICD-10 PCS root operations must perfectly reflect the anatomical reality of an excision versus a resection. Equally important are those Z-code sequencing rules. Your principal diagnosis has to establish the nature of the encounter using Z40 for prophylaxis intent or Z52 for a living donor. And then you rigorously support those with secondary codes like Z15 or Z80 to define the underlying risk driving the whole intervention. This brings us to the ultimate stakes of our work here in MDC23. Precise Z-code sequencing and meticulous prophylactic documentation do so much more than just generate a code. They actively protect your hospital's revenue from aggressive payer denials. By capturing the complete, accurate narrative of living donation and preventative care, you are defending the medical necessity of these life-saving interventions and honoring the clinical truth of your patient's encounter. I want you to think deeply about the documentation at your own facility. Are your clinical records robust enough, with genetic markers and family history clearly mapped out, to immediately defend a prophylactic surgery against a commercial denial? As you evaluate your own audit readiness, get ready for our next session. Join me for Part 121, where we will plunge into the Advanced Medical DRG Deep Dive for Major Diagnostic Category 24, focusing on multiple significant trauma. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding, and I'll see you in the next class.